And so I'm going to ask the panel to introduce themselves, starting with Kevin.
Hi there, just had to unmute myself, typical video chat nonsense. So pleased to meet you, I'm Kevin Burton. I'm a surgeon who works in the west of Scotland, and I've dealt with gynaecological cancers for the last 15 years. We do a lot of advanced surgery for ovarian cancer, and we're also very interested in how we're progressing this sort of the excellent care we provide in Scotland to make sure it's as good as it can be, and link very well with other teams around Scotland. So hopefully we can address any of your questions you have today.
Thank you, Kevin. And Charlie, can I ask you to introduce yourself?
Hi, my name's Charlie Gourley. I'm a medical oncologist from Edinburgh, which means I give people chemotherapy and some of these new that you've been hearing about. I do a lot of clinical trials, and I also have a laboratory group that does research into the genetics of ovarian cancer.
Lovely, thank you, Charlie. And Lorraine, can I ask you to introduce yourself, please?
I'm Lorraine, and I'm based here in Edinburgh at the Royal Infirmary Hospital. I'm based on the surgical side, and I've been in the team since 2014. And I meet most of the ladies from the beginning when they get referred from the GPs and when they have their surgery. So some of the ladies, I don't get to meet them until they come over to have surgery.
Okay. So where are we starting? So to start with, we received a lot of questions about using maintenance drugs and personalised care. So Charlie, perhaps we could start by explaining what the standard treatment that women might receive for ovarian cancer, and then we can move into some of the specific questions that we received.
So for newly diagnosed ovarian cancer, the standard treatment is in the first place to get chemotherapy and surgery, and that either means getting surgery first followed by chemotherapy, or it means getting 3 cycles of chemotherapy first and then surgery, then 3 more cycles of chemotherapy. And sometimes in certain circumstances we can give a drug called bevacizumab, which is a drug that blocks the blood supply to the tumour, and sometimes you can give that with the chemo. And then once the chemo and the surgery is all finished, then depending on the individual circumstances, some patients may be suitable for maintenance bevacizumab. That means continuing this for about another 11 or 12 months, well, 11, 12 cycles. So, about 9 or 10 months. And then some patients will be eligible for maintenance treatment with a new drug called a PARP inhibitor. And at this point in time, that in the first line setting, that means after you've had your chemo and your surgery, that is just restricted to people who've got BRCA1 and BRCA2 mutations at this point in time, but that may change soon. So that's really the first line setting.
Lovely. So somebody's asked us, the first question we received is, what does the picture for access to maintenance drugs in Scotland and the UK look like now and in the future?
So right now, there are a few differences between Scotland and the rest of the UK. So in Scotland, we can use bevacizumab for stage 4 disease, but we're not at this point in time allowed to use it for stage 3 disease. In England, they can access bevacizumab through the Cancer Drugs Fund for stage 3 disease where there's been some cancer left after the operation. So that's a slight difference there. However, on the other side of the coin, in patients whose ovarian cancer has come back, under certain circumstances in Scotland, we can give bevacizumab in the relapsed disease setting, whereas they're not allowed to do that in England. And actually, if you ask me, that's a more important thing than being able to give it first line. In terms of these new drugs, right now, as I say, we've got access to this drug called olaparib, which is a PARP inhibitor in patients who've got BRCA1 or BRCA2 mutations for what's called first-line maintenance therapy. And that is true both in Scotland and in England. And then in patients whose cancer has come back, we can use maintenance PARP inhibitors in Scotland and in England in people who don't have a BRCA mutation, as long as they fit certain other criteria. And so the access across Scotland and England right now for PARP inhibitors is pretty similar. There are some slight differences in terms of which PARP inhibitor you can use, but actually we can generally get the drugs we want. That's the honest truth. Now, in terms of the future, there have been some really very good new studies done that have suggested that in the first-line setting, giving a PARP inhibitor to patients who don't have a BRCA mutation is a good thing to do. And those PARP inhibitors have now received licenses. They got these licenses a couple of months ago. But they're currently going through NICE, which is the organisation in England who decides whether they can be used, and also going through SMC, which is the Scottish equivalent of NICE. And so we're waiting to get opinions as to whether we can use these or not in these people first line who don't have BRCA mutations. Actually, you know, I will mention that one of the drug companies has given us what's called compassionate access to one of those drugs. So we can actually access the drug even though it's not SMC approved just now. But that ability to access it that way may disappear once SMC make a decision, regardless of whether that's positive or negative, because if SMC say no, then clearly the drug company aren't going to continue funding it forever without getting paid for it.
Thank you, Charlie. We've had a question about combinations of those drugs. So someone's posed a question which says, a good deal of progress has been made in the field of maintenance drugs in recent years. Is there any evidence in combining some of these drugs to increase how well they work?
Well, yes, there is. So there have been studies done both when the cancers come back and also in newly diagnosed cancer to look at combining these drugs. And it's mainly the PARP inhibitors, which are the real exciting new drugs, and these drugs that block the blood supply to the tumour. And so there's some of the studies in the relapse disease setting, that is when the cancers come back, suggest that putting two of these drugs together, such as bevacizumab plus olaparib, that's a PARP inhibitor and an anti-angiogenic drug, may be a good strategy. Now, there have been a few conflicting trial results. So some of the trials suggest this is a good strategy. Some of the trials suggest, well, it may not have that much impact. However, probably what is most interesting is that there's been a new first-line trial that has combined olaparib and bevacizumab. And it demonstrates that adding the olaparib on top of the bevacizumab is definitely beneficial. And so that's one of the drug combinations that currently is being looked at by SMC as to whether we will be able to prescribe it in the future. So there certainly is some evidence that these drugs together may be beneficial. And then just to add one more sort of complexity to it, there is a new form of agent called an immunotherapy agent. And currently there are about 4 or 5 big trials being done around the world looking at whether adding immunotherapy to PARP inhibitors and also in some cases to anti-angiogenic drugs, whether the combination of those 3 things together actually adds more effect. And so we should have the results from those trials in a couple of years' time.
Great, thank you. So people, kind of on a similar note, people might have heard talk about personalised medicine or personalised care. What does that mean for women with ovarian cancer, and how will it influence what treatments people can get access to?
Is that for me?
Yes.
Yes. So yes. So I think the first element of personalised care is to understand that ovarian cancer is not one disease. So there are at least 5 different subtypes which differ according to what the pathologist sees when he or she looks down the microscope. So the commonest is called high-grade serous, but there's also low-grade serous, endometrioid, clear cell, and mucinous. And those all behave in a very different fashion and all have different sensitivities to treatment. So they all respond differently to chemotherapy. Some of them, such as low-grade serous, doesn't respond all that well to chemo. The only one that really responds all that well to radiotherapy is clear cell. So these are real differences. And that's the first level that we can individualize care. But then the next level that we can individualize care is when it comes to the genetics of the tumor. And so we've already spoken about people with BRCA1 and BRCA2 tumours and how they respond differently to both chemotherapy and to these new drugs, PARP inhibitors. And it's now becoming evident that there are other genetic lesions in the tumour, some of which may have been inherited, some of which just arise in the tumour, that some of these other genetic aberrations or genetic changes can also predict how well patients will respond to a particular treatment. So we're currently just dissecting this. It's furthest down the line in high-grade serous ovarian cancer, but we're also looking at it in the other subtypes. And so really it's a question of doing genetic sequencing in the tumours and looking at how well the patients respond to these new drugs, so we can kind of link these two things up. So if a patient has a particular mutation in their tumour, are they more likely to respond to a particular treatment? And a lot of that's underway. I think the main example of where it's really worked out is with regards to BRCA1 and BRCA2 mutations.
That leads me into a question that we've received in the chat box just now. So someone's asked whether we can say a little more about the RAD51D mutation, which is less spoken about than the BRCA mutations.
Yeah, okay, so RAD51C and RAD51D, those mutations can both cause hereditary ovarian cancer. So what that means is if there's a mutation in these genes and they're inherited by a lady, then there is an increased risk that she'll get ovarian cancer because of that. And there's a suggestion that patients with RAD51C and RAD51D mutations would be more likely to respond to PARP inhibitors. And I think that's reasonable based on the biology. Unfortunately, there has never been a trial that's recruited only RAD51C or RAD51D patients. And the reason for that is because they're so rare that it would be very, very difficult to get enough patients to do a proper trial. However, I think there's a very good argument that these patients will likely behave similarly to BRCA1 and BRCA2 patients.
Great, thank you very much, Charlie. So we're going to move on now to some questions that we've had in specifically about COVID-19 and what's going on in terms of cancer care during the pandemic. So Kevin, I was hoping you can answer this question for us. How do you expect the ongoing pandemic to affect ovarian cancer surgery and treatment across Scotland in the immediate future?
Yeah, it's been a really sort of trying time for all the teams looking after patients with ovarian cancer. We appreciate there's a need and an urgency to progress with the treatment, both chemotherapy and surgery, but we also appreciate the need to keep the patient safe when they're having the chemotherapy and surgery. And in hospitals, it's been very difficult trying to keep patients in an environment where the chance of them getting a COVID infection is as low as possible. It's never going to be possible to keep it at absolute zero, but we want to keep it as low as we possibly can. So there's a number of different elements where we've sort of reviewed our sort of processes, and in the hospitals now we've tried to get different pathways for patients. We're trying to ask patients to isolate as best they can for 2 weeks prior to coming in for a major surgery, because if they can isolate for 2 weeks and all the patients in that same area have isolated for 2 weeks and all the patients come into hospital have had a negative COVID test, then hopefully that's the safest possible environment for them to have their operations. Inevitably, there's been some situations where we haven't been able to the number of wards in the hospital are limited and the number of beds in the hospital are limited. And if you have areas where there are COVID patients, the number of beds in areas become even more limited. So we have had some situations recently where we've had to reduce the bed capacity to deal with to have a safe environment for patients. The unfortunate knock-on effect from that has been we've been able to perform less operations under those circumstances because we've had less beds for patients to be looked after their operation. But we're always looking at sort of making sure we're as flexible as possible and adapt as we can to make sure that we look at all the opportunities for having operations and freeing up capacity to let us do operations as well. We've had discussions to move operation between hospitals sometimes, so we've had to do that, and not so much for ovarian cancer cases, which are complex cases that need joint surgery often, but we've managed to do some other cases in other hospitals, and that frees up some capacity to do our operations for the ovarian cancer patients. We've also been various groups that have met at a National Cancer Recovery group, and because during the initial phases of the pandemic, the medical oncologists and the surgeons who deal with ovarian cancer were shown to be very effective at making sure we kept as much access to theatre as we could. And we managed to actually get our numbers of patients waiting for ovarian cancer down, whereas a lot of other cancers found their waiting times going up. We've been invited along to the National Cancer Recovery Group. So we have a voice at that platform at a national level, feeding into government, trying to persuade them for the need to be flexible at how we approach ovarian cancer now and for the future. Because what we want to be able to try and achieve is have a situation where we look at this as a national picture, and that no patient has to wait any longer than they should for their surgery. So we're certainly part of those discussions now, because we have shown ourselves to be effective, and hopefully that will lead to sort of maintaining the progress we made with ovarian cancer. But it's not easy, and I wouldn't say it's a perfect picture, but it's the safest, best picture we can get right now.
Great, thank you, Kevin. So we're going to move into some questions now about recovery and rehab. So our first question, which I'm hoping that both Kevin and Lorraine can pitch in on, is somebody's asked, how long does my body take to heal after a total abdominal hysterectomy? Shall we go to you first, Kevin?
Okay, so it really depends on the complexity of the operation that's been required. The more complex the operation, the longer it can take before you return to normal function. What we'll say to most people is that all being well, you've been in hospital somewhere between 4 and 8 days after the operation. The more complex the operation, the longer your time in hospital. And thereafter, we look to get you home fully functioning. It'll be hard when you first go home as well, in that people have to sort of adapt to new environment, new circumstances, and sort of have to learn to do more for themselves at that point in time. But by getting people up and moving early after their operation, by preparing them as best we can before the operation, then hopefully we get patients back to be able to be fit for the next steps in the treatment, rather than maybe sort of 4 weeks after the surgery. Until you actually feel completely normal after your surgery, it might take up to about 6 weeks. And obviously, everyone's different. A 40-year-old will recover quicker than many 80-year-olds. But that being said, you get some very fit 80-year-olds who'll put the 40-year-olds to shame on occasion as well. So, so a wide variety, but hopefully within about 4 to 6 weeks, you'll be back to normal.
Great, thank you. Lorraine, do you have anything to add to that in terms of rehab and getting back to normal?
It's just agreed on what Dr. Burton said, that it takes up to 3 to 4 weeks to feel yourself again in terms of energy levels. And just to confirm that we do try and encourage you to get up and about as soon as possible following the surgery, and when you do go home as well. And most of the patients that we do speak to, by the time they go home after 10 days, they're out and about and engaging in more activities. And it's just to remember that we know we want you to exercise and increase your mobility, but it's all to remember to have a good rest and not overwork your body, because you don't want to end up not being able to actually progress in your recovery. So it's just increasing mobility and doing more, but at the same time trying to avoid your body getting more tired by overdoing things. But yeah, in general, by the time we see you about 3 weeks, 4 weeks post-op, most people would have recovered from the surgery and ready to go back to have more chemotherapy.
Lovely, thank you. That kind of leads me nicely into my next question. So somebody's asked, how long will it take for me to get my walking back to the way it was before my diagnosis? And they've given a little bit of extra information. They said I had 6 rounds of chemo and an operation. My last chemo was October 2019. Lorraine, would you like to start on that one?
Yeah. Hi, thank you. So it's difficult. It's so dependent on what the person's the level of activity was prior to diagnosis, and also how their journey has been. So some people have had more complications than others, and it could be that you might not gain to where you were prior to diagnosis, but at least to be closer to where you were at the time of diagnosis. So it does take time, and also to remember that you might have some side effects from chemo, not just surgery itself. So it's always good to consider that as well. And just to carry on doing what you can and not to give up, but to continue to find other activities that are gentle to your body, but at the same time making you progress in what you can do. So the walking, anything that can strengthen your muscles and to increase the mobility that way. So it will get better, but it just be also realistic that you might not be as prior to diagnosis, but getting closer to what you were, at the time.
Lovely, thank you. So our next question is about what we could do better. So somebody's asked, what could we do better in terms of rehab for improved surgery and treatment outcomes, as well as better mental health outcomes for patients? Kevin, Lorraine, and maybe Charlie, maybe you can share your thoughts on this for us.
I'll say something and then I'll let the consultants confirm that as well. It's always good to stay active, not easy because it's the time, especially at the beginning, it's the time that you're getting the diagnosis and it's all the emotional stress as well. But it's always good to stay as active as you can, and especially prior to surgery, to keep being mobile and also have a good nutrition. Not very easy again, because you might have in some bowel obstruction symptoms, or you have ascites. If you're needing dietitian input, then you can do that at a very early stage to build you up for the surgery. And emotionally and psychologically, to ask as many questions as you can, so that when you're consenting for procedures or anything, that you've got enough information about it. Ask as many questions as you can, and know that you're not alone. You do have people to support you and signpost you to the right place where you can get support. So that would be what I would advise. So the more information and advice that you've got prior will help you as well on the journey to recovery.
I think Lorraine's answered that question very well, and I couldn't agree more with everything she said. The colorectal surgeons in the west of Scotland have got some really good evidence now that rather than rehab, there's a thing called prehab. So getting patients fit before they have their surgery, or as fit as they can possibly be before their surgery, will certainly influence and improve their outcomes after surgery as well. Everything Lorraine said is absolutely correct. The more we can get patients moving, trying to be more physically active, stopping smoking, anything that's associated with a good health outcome will help them after the operation as well. And certainly there are a number of sort of cancer charity funded projects to encourage that as well. I think there's one called Move More that's sponsored by Macmillan, in terms of getting patients prepared and ready for a surgery as well. So I would agree with everything Lorraine said, and very little to add.
Great, thank you. So we're now going to move into talking a little bit about recurrence. So women often tell us that they struggle with worries that their cancer might return. And we've had a few questions around that as well. Someone's asked us, is there anything I can do to help my chances of not having a recurrence, or is it something that's beyond my control?
Well, it's my belief that it is beyond your control. I know that some people may disagree with that, and people think that there may be sort of complementary strategies. I mean, we will do everything we can to minimize the risk of the cancer coming back, and that's by combining the best possible surgery with the best possible chemotherapy and the best possible other drugs, whether they be PARP inhibitors or bevacizumab, or trials. So I guess one way you might improve your outcome is if you get the chance of a clinical trial. Obviously, we can't guarantee that entering a clinical trial will improve your outcome. So I guess maybe the best example is that if you get the chance of a trial, it might be well worth considering it. But other than that, I don't think there's a lot you can do. I think Kevin and Lorraine have mentioned, staying fit, staying active, and having a positive attitude. I think those are the best things.
Thank you. And I guess that kind of leads us to a question, which is, what advice would you give someone who's finding it hard to deal with worries about recurrence? Maybe we can go to Lorraine first.
I think the best thing to do is to be open about it and talk about it, and allow yourself to talk about it, either with your family or the health professionals, and then be able to advise on ways that you can help, not overcome, but at least deal with it on a day-to-day basis, or other things that you can do to help you along the way. So it's more getting, psychological support, because we do have services for psychological support, and that can be via the NHS, or it can be through Maggie Centre, with Macmillan as well. And we also have, for the people of the west of Scotland, the cancer support, Scottish cancer support as well. So it's just knowing that there are people out there to help you, with these feelings and the fears, and also what can happen if that does recur. What are the treatment options that will be available if that does happen in future?
Thank you, Lorraine. So we've touched on talking about chemo, surgery, drugs today, but some women might take a decision that chemo or maintenance treatment isn't right for them or isn't right for them anymore. So again, Lorraine, perhaps you can give us an idea of what kind of treatments and services are available for women if they decide that that kind of treatment isn't right for them anymore.
Sorry, I didn't quite catch the first bit of the question.
Some women might make a decision that chemo or kind of a maintenance treatment isn't right for them anymore. So I just wondered if you could give us an outline of what kind of treatments and services are out there for women.
So if somebody decided not to proceed with their treatment, that means they've decided to have best supportive care, if they're not going ahead with treatment. So we try and engage the community team as soon as possible, and that they're aware that's what the decision has been made by the patient, and get the GP involved in their care as well. So they might not need intervention at the beginning, but it's good to know what's available for them in the community in the event that they need that support. So that's engaging with the community palliative care nurses as well, and having a plan of what we need to do, anticipatory care planning, so that if something does happen, if you need intervention, do we need to come back to the hospital, or is something that can be managed in the community? So it has to be a planned care for that can be signed off, but it can change depending on the patient's needs, and also one person might make a decision today, but in a couple of weeks' time, it might change depending on their clinical condition as well. So just to know that if you decide not to go ahead with treatment, it doesn't mean that there won't be any further care provided, but it's the community team taking care of continuing with the care and managing your symptoms. And also that includes giving you psychological support for the patient and their families as well, because it can be difficult if a family decides not to proceed with treatment, and it's hard on the relatives as well, maybe wishing that someone proceeds with treatment. So they'll need a lot of psychological input and support for that, respecting the patient's decision not to go ahead with treatment. So it's support for the patient and also support for the family members as well.
Great, thank you, Lorraine. I'm just going to cycle back a little bit. So Charlie, you touched on clinical trials as a way to access kind of new and emerging treatments or new combinations. If someone was interested in accessing a clinical trial, could you talk us through the process for going about that?
Yeah, so it would simply be a case of discussing things with the oncologist, and most of Scotland's lucky in that the ovarian cancer is largely coordinated through the 4 big centres and 5 slightly smaller centres and 5th slightly smaller centre in Inverness. And as far as I'm aware, all of those centres have some trials available, and what's more than that, we do talk a lot to each other. So if there was a lady in a centre where there wasn't a trial suitable for her, then her oncologist would likely know whether there was a trial open elsewhere that she could be referred to, and we take referrals across Scotland for clinical trials. So it's a case of discussing it with your medical oncologist and saying, I'm really interested in a trial. Do you have something that might be available for me? And, he or she will say yes or no, or there may be something elsewhere. And then you would get referred to wherever the trial was, and they would discuss the pros and cons with you. So, what's very important is that the patient gets full opportunity to make an informed decision about the entry into the trial. So It'd be described to them in full. They'd be given written information. We wouldn't be allowed to take a yes or a no that day. We would have to let them go away and think about it. And you'd also get introduced to the clinical trial team, which would be, it's usually a research nursing team that runs these clinical trials. So that's sort of how it works.
Lovely, thank you. So this leads us into, I think, the last section of our questions that we got, which are around research and new treatments. So someone's asked a really nice but very open question and said, I would like to know about research into new treatments. Is there anything promising on the horizon that you could share with us?
Yeah, so well, obviously the PARP inhibitors have been a massive breakthrough, there's no question of that. And we're hoping to hear good news about immunotherapy plus PARP inhibitor combinations. I'm not all that sure how good that will turn out, because immunotherapy has been very good in other cancers, but maybe slightly disappointing in ovarian cancer. The hope is that by putting it together with PARP inhibitors, it might be effective. I suspect we still have a bit to go to crack that nut. But I think what is exciting is the discovery that PARP inhibitors work so well has led drug companies to look at other agents that work in similar but not identical ways to them, that work on something called the DNA damage repair response. Because the cancers don't repair DNA as well as normal cells that makes them sensitive to PARP inhibitors. So the question is, can you do this in another way that would be even more effective than PARP inhibitors, and might mean that patients who wouldn't respond to PARP inhibitors might respond to these other drugs. And so now early phase trials going on of these agents, these what are called DNA damage response agents. And I think they are really, really exciting. So I look forward to seeing the results of those. And then probably slightly further over the horizon, there are other immunotherapy strategies that are not drugs, but are looking, at giving people their own kind of immune cells back, taking their immune cells out and adapting them and putting them back. And these strategies have been really successful in some hematological cancers. And it's a bit further away, but it would be absolutely fantastic if we could develop a strategy like that in ovarian cancer, and that research is going on.
Thank you very much, Charlie. So I'm afraid that we're out of time. I am very conscious that there's been lots of questions that we haven't been able to answer, so I'm very sorry about that, but I'll tell you the details for our support line at the end, and hopefully if you're interested and your question hasn't been answered, you can give us a call and we can help you out with that. So before we finish, I'd just like Kevin, Charlie and Lorraine to share with us one thing that they'd like people to take away from today's question and answer session. So I'll start with you, Lorraine.
It's just to know that there is a lot of people available to support you, and at a local level to be in touch with your clinical nurse specialist as the first point of contact, and also to use the services like Target for any other information, and to be able to talk about it. So it's hard sometimes to talk about your diagnosis and what you're feeling with your family members. It's also, you can use your clinical nurse specialist or other support services to do that. And also encourage family members to seek help, because when you're fully, you've got enough support, then you'll be able to support your loved ones as well whilst they're going through this journey of cancer. So just to seek help, and there's a lot of help out there. If you need help, we can signpost you to where you can get the most help from.
Thank you, Lorraine. Charlie, could you go next?
Yeah, I would just say that the message is that there's plenty of hope. I mean, these new developments are coming through pretty quickly. I mean, ovarian cancer has been lucky in that, there have been many more developments in this sort of cancer than there have been in most cancers, I would say. And I think there is room for optimism that there will be more developments in the next 5 years.
Thank you, Charlie. And over to you, Kevin.
Surgical field of ovarian cancer has constantly been evolving as well, and we are very keen to try and make sure that the treatment you get in Scotland is as good as anywhere else. And we've certainly been much more aggressive in how we approach ovarian cancer surgery, and we're now starting to look at the promising results for operating in patients with recurrent ovarian cancer as well. And we're certainly trying to see if we can establish a service for that within Scotland too, because what we really want to try and achieve is sort of the highest level of care you can possibly get anywhere.
Lovely, thank you. So we're going to finish up now. Thank you everybody who sent your questions in. We hope you found it helpful. If you have any further questions or concerns, or would just like to have a chat, the support line is available. You can email us through the Target Ovarian Cancer website. You can just Google that, or you can call us on 020 7923 5475. So that's me signing off for now. I'm going to hand you back to Soraya, who's going to